Hi, everyone. Thank you for coming to the talk today. I am Dr. Tom Black. I am an LPC and an LMHC, a licensed professional counselor and a licensed mental health counselor. Different states use different names for my profession. We'll talk about that as we go through. Today's discussion is on LPCs and healthcare, the impact and insights that professional counselors have and can bring to overall healthcare. This is significant and important to the things that we're doing because about 70 to 75% of professional counselors or mental health counselors or clinical mental health counselors, as I said, different states call them different things, but we all do the same thing, are females and are women. And the work that we do is often overlooked when it comes to whole healthcare and the healthcare system. So it's important to, when we're working towards understanding of whole health and individuals' difficulties, that we address all of their needs. I think that's becoming more and more well known and accepted and prevalent, especially since COVID and the things that we went through. But here's my contact information. I am the executive director of the American Association of Forensic Professionals, but obviously the work I do carries over in a lot of different ways, not just in the forensic realm. I've been an LPC for 25 years or so, and I've been working in the field and in the profession with courts and individuals, not just in courts. I started out in the school systems for nearly 30 years. So it's a passion I have, advocating for the profession, advocating for individuals who are in need of services, and then making sure that people have a good understanding of what adequate, appropriate professional services look like. I've been working in the regulatory side of things since 2012 on licensure boards and then with national organizations. So I've seen a lot of the bad that comes from unprofessional conduct or a lack of coordination amongst professionals and how that can impact individuals. So I have a passion to elevate the things that we do to make sure that the populations, particularly the underserved and underappreciated populations, receive the support that they deserve. So as we talk today, we'll go through these things, what exactly an LPC is, what their role in healthcare is, why it's important, how we as LPCs and mental health counselors contribute to whole health. And then if we have time, we'll get into a few case studies and examples of the impacts, and then how accessibility of LPC services works, how we can become and are oftentimes the first point of contact and can be important in early intervention to prevent escalation of mental health issues, which often correlates to physical health issues. So we'll then get into the different range of services provided in counseling, individual, group, family counseling, and how we try to treat individuals from a holistic approach, looking at all the different aspects of their personality, their physical health, their mental health, their social health, their emotional health, the support systems that they have, diet, exercise, sleep, and how we try to bring all of that to the table in the coordination of care that we do. Then we'll do briefly some of the different therapeutic modalities, and then how that is tailored to patients' needs, and then different effective types of treatment for various healthcare conditions. So, and maybe get into some examples of things, different types of things that we do. Obviously, it's my belief that LPCs and professional counselors are extremely vital to healthcare. The benefits of psychoeducation and therapy have been shown repeatedly through outcome studies, research, and just anecdotal data in our interactions and involvement with people. Having somebody that you feel is on your side or can be a support or has time to sit and listen to. Oftentimes, as healthcare providers, we're just bouncing from the next person to the next, doing the best we can, especially, again, as things have escalated over the last few years and expectations have changed with differing needs and expectations of society through the digital age. As obviously I'm here presenting from probably maybe halfway or all the way across the country virtually in real time, but also asynchronous for a lot of you. So we understand that the more information, appropriate, correct information that an individual has, that enhances their understanding and promotes their active engagement for better outcomes. It's been shown over and over again that people have more buy-in when they have understanding. So we try to spend time and go through that and explain difficult things to difficult people, or in difficult situations rather. We try to incorporate evidence-based techniques. We understand that these things strengthen treatment efficacy and align interventions with proven effectiveness. We want to make sure that everything that we do comes from a place that shows positive outcomes. And then number one, the most important thing we do from a building rapport perspective in the beginning is building therapeutic alliances. Our entire goal, and we have a good understanding from day one in our training and education, that without a therapeutic alliance, there's no trust, there's no collaboration, and there are no positive treatment outcomes. So we work hard to be genuine, to be present, and to work on ensuring that we have that good rapport. I thought it was important to talk about this topic because I think there are a lot of other mental health professionals who have had licensure for much longer time than we have. And there's a lot of lack of understanding of the different things that we do and how similar we are in a lot of ways to other mental health professionals. In most jurisdictions, in most states, everything's a little bit different with licensure laws and regulations and things like that. And then every organization is a little bit different with the implementation of how you move through and have expectations of different employees and different professionals. But in most states and most jurisdictions, professional counselors and licensed counselors have similar training as other mental health professionals and can do just about anything they can. We can do individual therapy, we do intakes, we do crisis management, we do testing and psychometrics, we do crisis intervention, so family therapy. Oftentimes, I think because our profession is relatively new from a regulatory standpoint, several states just got licensure within the last decade, for example, compared to other professions that have been around for decades. There's a lack of understanding there, but I want to kind of elevate that level because the vast majority of mental health professionals in this country are licensed professional counselors or similar, not other mental health professionals. In Georgia, where I'm at, for example, there are more LPCs than all of the other mental health providers combined, and that's pretty standard. There are some states that is not the case, but as professional counselors, we like to use, as I stated, the holistic approaches. We like to integrate and have a good understanding of mind, body, and spirit connections to make sure that we understand the wholeness or everyone's overall well-being. We appreciate that it's impossible to deal with or address issues in a vacuum. It's impossible for me to take Billy, for example, out of his family and only address his thinking errors or his emotional reactions to things without putting them in context of the situation that he's in at home, at work, at school, or wherever he may be. I worked with an individual when I first started years ago who was incarcerated. He was a 16-year-old kid. He was incarcerated for drug dealing. And he was not overly excited to be leaving the incarceration. And I asked him why. And he said, because when I get home, my grandparents will expect me to go back to dealing drugs again because it helps support the family. So no matter what work I did with him individually, without understanding the holistic approach and the family systems approach, nothing was going to be successful. So obviously we had to put in a lot of different supports within that family system to make sure that he did okay. And it was just like everything else. A little bit of improvement, some setbacks, a little bit of improvement, some setbacks. So we try to implement everything in a culturally competent and sensitive way. Oftentimes, there are marginalized populations that we deal with who are overlooked, and it becomes super difficult. In every area that I've ever worked or lived in the United States Army, growing up in California, living in Arkansas, living in Florida, and now in Georgia, the populations that I've been around have been significantly diverse. So I have an appreciation for that. And I appreciate that my profession has an appreciation for that. We look at and appreciate individual differences, but understand sociological and group differences and similarities as well. And we try to use that information to improve treatment relevance and effectiveness. We want things that we do to make sense to the people that we're talking to.
One of the main things that we do as LPCs is we want to promote mental health awareness. We want to make sure that uh, our leaders, our governors, our state representatives, and senators, and at a national level have a good understanding of the needs and the difficulties that are going on currently in our society associated with mental health awareness. This was a huge uphill battle several years ago, but since COVID, one of the few bright spots that has come out of that horrible situation is that there seems to be a much more significant awareness of mental health conditions and issues. The stigma has been reduced significantly, and more people seem to be more open to that. It continues to be a major issue, especially within certain subsects of individuals. Southern males, for example, have difficulty going to therapy or talking about their issues because of the stigma or societal expectations. So it's important that we as a profession are there to kind of wave the flag and raise awareness. We also want to make sure that individuals have a sense of feeling of acceptance and don't have to worry about that stigma of a diagnosis or of having to go to therapy and hiding from those things. So next, obviously, when somebody is aware of mental health issues and they decide to come get treatment or to work through the process, our goal almost always, from a building block standpoint, is to enhance coping skills, to help people learn how to develop those things and use those things. It's not our job to tell people what to do, it's our job to help them understand and find a way by helping them through processing whatever their situation is. So, and one of the things I love most about my profession, and I think everyone would agree with this in the health field, is also one of my biggest frustrations in this profession is what works for one person today may not work for another person today, and what works for me today may not work for me tomorrow. So we have to have a lot of different tools in our toolbox in order to move into the improvement of quality of life through psychotherapy. Almost everything we do is built upon or building towards somebody finding some way to improve or enhance their life through the process of psychotherapy, what used to be called talk therapy. So our primary goal, which is built upon doing a comprehensive biopsychosocial, doing a comprehensive psychological assessment, looking at all mental health, social, cultural issues that are enhancing or impacting their concerns, and then working with their other healthcare providers. The number one reason that depression, major depressive disorder, for example, is misdiagnosed is from sleep apnea. So we have to have a comprehensive biopsychosocial or social history, use their medical history, and collaborate with other health professionals to make sure that their entire well-being and overall quality of life for them is improved and enhanced. So we know, as I stated previously, that when we address mental health issues or behavioral health issues, that enhances physical health outcomes. We're all connected, right? It's impossible. I talk about this all the time. There's a difference between the mind and the brain being the organic organ, and the mind being the more esoteric ins and outs, the neurotransmitters and the processing and the electrochemical memories and traces that we have, but they're impossible to separate in living whole human beings. So our job is to address whatever those things are, whether it's stress or inflammation or risk of chronic diseases, by helping improve overall mental health and addressing those things through coping, through processing, through development of support resources, and sometimes just being a sounding board. When I first started, I was very much outcome oriented. As I stated, I worked in a school system. I also worked in the court system, and I worked with social services, children in foster care, families involved in the foster care system. So we had very limited amount of times and very serious issues that we were dealing with. And I didn't give a lot of stock to the dialectical techniques. I didn't give a lot of stock to the kind of whole wellness things that since then I have learned are super significant. Active listening, acceptance, non-judgmental, being myself and being authentic. Oftentimes that's all people need, is just a place to sound off and throw their issues towards. So we also know that our mental health and behavioral health influences our behavior, our relationships, our emotions, our motivation, and our resilience. Everything there are a lot of different theoretical techniques around talk therapy or psychotherapy, and we'll talk about some of them later. But the ones that I find most effective are the ones that include treating the whole person, looking at how they think about things, looking at how they act in certain situations, and looking how they feel about different things. So when we can do those things and we can improve our behavioral health or mental health, then you see where they say a rising tide rises all ships, right? So, or all the boats. So we see that it influences. When I feel good, I act differently than when I feel poorly. When I feel good, my relationships seem to go a little bit better than when I feel poorly. When I feel good, I have more motivation and better resilience. I can deal with more when I'm feeling well. When I'm feeling well emotionally, when I'm feeling well psychologically, or when I'm feeling well physically. And then we know that integrated care improves holistic health. So when you take everything and you combine it all together and you coordinate with other mental health providers and physical health providers, it leads to better patient outcomes. I've worked with several groups over the years who have acknowledged that the behavioral health component is often lacking. I've also worked with several groups in the behavioral health side who don't coordinate with mental health providers, I'm sorry, with physical health providers or psychiatrists or the ilk for medication or other healthcare related issues. And they find that their outcomes aren't as significant as people who are working on that whole health individuals. So it's significant and important that we do that. So the primary behavioral technique that is utilized in therapy is cognitive behavioral therapy. I talked about this yesterday and got questioned by a judge about it. It's the only therapy that has significant and substantial scientific validation for outcomes that are based on it. Now, there are lots of different versions of CBT. There's cognitive processing therapy, there's rational emotive behavior therapy, there's dialectical behavior therapy that have all shown to have effectiveness. There are other types of therapy that are less talk derivative that show effectiveness, but cognitive behavior therapy is foundational in a lot of things that we do. And it's something that we utilize to help people identify negative thoughts, which are driving inappropriate behaviors or negative emotion states. And therefore, once you can identify those negative thoughts, you can confront those negative thoughts, and then you can start feeling better about things. It's very much based out of the Stoicism philosophy. Matter of fact, a lot of it was derivative from that. So the ancient Greek and Roman philosophies. We utilize mindfulness techniques. This is the stuff that I was saying in the last slide that I didn't think very highly of when I was younger, but I've since learned that that was not the case. I was not very well informed, but at the same time, I was using those techniques without understanding and appreciating that I was using those things. I've always engaged. I've been active. I've engaged in exercise and an active lifestyle, active social lifestyle. I have a good support network of friends. And those are things that I encouraged all of my patients to do from day one when I started 25, 30 years ago. But it's not something that I considered as part of my therapeutic milieu, but it really is. It's part of what we do. And when we incorporate those things, now mindfulness to some people where I live and a lot of the populations I work with is a dirty word. So I don't necessarily use it that way, but I talk to them about getting out and being active and developing a routine and having a support network. And those are things that we do as part of our process as therapists. And then trauma-informed care. It blows my mind to this day. When I first started out, trauma wasn't a major thing that we looked at, psychological or physical trauma. We would note it and then we would move on. We were primarily focused on from a CBT standpoint on the here and now and moving forward. But there seemed to be a glossing over of those things. I think in the last, even prior to COVID, in the last 10 or 15 years, that we've found how ill-informed that is. It's hard to, looking back at that whole individual and a holistic approach to things, it's hard to move forward when you're dragging a bunch of trauma with you. And I use that obviously metaphorically, but oftentimes it's described by individuals as they feel like they're tied to different blocks and cinder blocks or concrete blocks, and they're carrying those along. So we try to provide trauma-informed approaches to address those past traumas and promote healing for individuals. So studies have shown repeatedly that the enhancing treatment adherence and health outcomes comes from the building of rapport, the establishment of the relationship, people feeling like they're listened to, and then their buy-in to holistic wellness. So addressing how they're acting, how they're feeling, how they're thinking, the things that they're doing, their diet, their sleep regimen, their social interactions, all of that, making sure they take medication. When you take one of those pieces out, then it's like having a flat tire on a car. You may still get to where you're going, but it's going to be a rougher ride and it's going to take a little bit longer. We work hard on preventing relapse. We talk about relapse in the sense of not just substance use, but everything: depression, anxiety, uh, post-traumatic responses. So when we try, or when we use integrated mental health care, behavioral health care, we find, and studies have shown, that relapse rates are much lower, and it minimizes hospital readmissions for better patient stability. Typically, when individuals are released from psychiatric hospitalization or even surgeries, there's a coordination of care with the case managers from the hospitals to be seen within a certain amount of time. And insurance companies have shown that their costs are much less significant when they have their patients, or their, I want to say providers, but they're the providers, when they have them connected with follow-up care and they can get the follow-up that they need. It leads to fewer readmissions, it leads to fewer emergency room visits, and that's one of the main goals that we try to do. And lastly, kind of along those lines, we try to improve satisfaction and quality of care. Oftentimes in our system, everyone is so busy, we're moving from one emergency to another, and that's obviously not the case for everybody. But in our sessions, we have booked usually 45 to 55 to 60 minutes with an individual. So we have time to process things, we have time to review things, we have time to let them vent a little bit more than in a typical emergency room situation, for example. And obviously, we're not doing emergency type care in a traditional outpatient psychotherapy. But having that time allows for more intimacy, more processing, and then them feeling better, the patients typically feeling better about what's going on and their investment in what's going on and their buy-in into that. So I think I said earlier, as it pertains to accessibility of LPC services, in most states and most jurisdictions, there are more professional licensed counselors than the other mental health providers combined. Not trying to knock anybody or say anything negative about any other, because we all work together and we're all needed. And within my core group of valued people that I consult with, or need help from, or when I have ethical issues or treatment issues that I'm not sure of, I have LCSWs and LMFTs and licensed psychologists and psychiatrists that I lean on for these things. So we all work together. The point of this presentation is that oftentimes LPCs are forgotten in that team process, or there's not an understanding of the things that LPCs are capable of doing. And I want to reiterate that every jurisdiction is different. Every organization has different expectations of their different professions. But in general, LPCs, LMHCs, LCPCs, whatever their acronym is and whatever their jurisdiction is, have similar or same level of training, experience, and education as those others. So because there are more of us, that helps us in providing timely access to mental health services. So we typically are the first ones that see. We help to do referrals, even though we're not primarily case managers. Some are, but as a profession, that's not one of our primary jobs. It is something that we do. We help coordinate between the patients that we see and the local resources. If somebody is having difficulty getting in for psychiatric support, for example, we work with a lot of psychiatrists in the area. If somebody needs some health care, then we can help turn them on to different resources. We work with the homeless organizations, we work with housing organizations, we work with the VA, we work with the Department of Defense. We have LPCs are embedded in many military communities. So we have those awareness. We have LPCs that are working in hospitals. We do diagnosis, we do treatment, we do assessment, we do evaluations. So early intervention is super important. It's one of the things that was lacking and is often lacking still in a lot of situations. But when I first started, it was not talked about hardly at all. I certainly did not see it very often. There was very little emphasis placed on avoiding issues, but a lot of emphasis placed on correcting issues. So because there are more LPCs and because there's a wider range of services that they're able to provide, we can help de-escalate situations or prevent escalation of situations when we get things at early stages. Particularly autism spectrum disorder, for example, in my mind, is a good example of this. When I first started, if I diagnosed a child with autism spectrum disorder, then that limited resources that were available to that child. But then as a society, we learned that early intervention and early identification leads to much better outcomes. So I don't know. I know the identification of autism has exploded significantly in the last 30 years. We see it much more than at least the diagnosis, not the behaviors necessarily, than we did 25 to 30 years ago. But I think that's because we're doing better early intervention and identification so that we can get the support and the services. And in the school system, we're seeing better mainstreaming of those individuals as opposed to just placing them in a corner somewhere. By using early intervention and the support systems of professional counselors, we're seeing a mitigation of more intensive treatment. So obviously that's not always the case. Obviously there are individuals who don't get early intervention, and there are some who do get it, but the intervention isn't successful for whatever reason, whether that's an LPC or a psychologist or a medical doctor or a nurse practitioner, a nurse or psychiatric nurse, whatever the case may be. So but oftentimes we can, and that can mitigate costly, prolonged, intensive treatment that leads to more significant disruption in the patient's lives. We're often, as I said, the first point of contact. We're able to facilitate early detection of mental health concerns. We identify symptoms at early stages, and then we can get that early intervention, which can lead to prevention of a lot of major issues. That then minimizes long-term impact of untreated mental health issues. Obviously, early identification and treatment of issues leads to more timely interventions, which leads to less prolonged issues or complications that can arise from other things. Individuals who have depression and are identified, or anxiety and are identified, or not identified rather, can then develop more significant issues. Or PTSD is a great example of this. If we identify somebody who's been exposed to trauma, we get them some support, their resilience develops consistent with the supports that we supply, then they don't necessarily develop chronic issues over time. And then by doing this, we're empowering individuals to be more proactive in their own mental health well-being and help them to take control of their life. And again, that goes back to buy-in, and that goes back to motivation, and then that enhances resilience. Resilience is their grit, right? Their ability to deal with issues as they arise. And that's, I say they, but that's true of all of us. By implementing these things, I think that's double slide, sorry about that. And then we do obviously comprehensive services. We offer individual counseling to individuals, we do group counseling. Individuals, great for some individuals or some situations. Group is better for some individuals and other situations. We know for substance use disorders or a lot of compulsive disorders or addictive disorders, that group seems to be more successful more often for most or more individuals. And that's because that's related to empathy and understanding. And I'm going to be much more likely typically to listen to or take advice from somebody who's been through and understands exactly what I'm going through when I'm going through that's significant, something that is significantly painful or causing me difficulties on a daily basis. Recovery is difficult, whether that's recovery from depression or anxiety or a substance use or a process addiction such as shoplifting or eating or sex. We're taking away the coping mechanism that we've used, regardless of how inappropriate it was, and the necessity to take it away. That change is difficult. So having people who can tell me there's a light at the end of the tunnel, I too have been through what you've been through and you can get through this, that helps. So, but other times individual is more successful. People want to have a level of intimacy and closeness to somebody on a one-to-one basis that they're not going to get anywhere else. Typically, a therapist, a good therapist who has good rapport with that individual, is going to learn more about that individual than probably anybody else in their life. They're going to learn their intimate fears and their desires and their thoughts in a non-judgmental space. We also try to tailor counseling approaches to their preference and dynamics. That becomes a little bit difficult. I remember referring a friend of mine to a therapist who I had heard good things about and knew from other clients and patients that she was a wonderful therapist. But this friend went and saw this therapist and said, I hate her. She's horrible. She doesn't talk enough. Or I've heard others say they talk too much. All of us have different sensitivities and different preferences. So it's good that we have a broad approach of different individuals. There are some therapists who sit back and listen. There are others who are more dynamic and more engaged and more directive. So there are enough of us, even though there is a huge shortage nationwide of all behavioral and mental health and healthcare providers, having the opportunity for different therapists with different treatment modalities and different preferences leads to better outcomes. So obviously, I think we all have an understanding of what individual counseling is. It's personalized treatment, it's tailored to address specific concerns, and it's for that very specific individual. Now, if I work with you and then I work with somebody else, the way I process things and the way I write it up in my notes might be almost identical, but the attention that you're getting is specific to you, and that's how it should be for everybody. Individual counseling allows for the fostering of coping mechanisms, sometimes coping mechanisms or just coping skills. Sometimes we'll role play. Sometimes we'll do some enhancement therapies where we'll practice different things. Teenagers, this was something that I did a lot. Teenagers wanted to express things to their parents, for example, or talk to teachers or their bosses, and we could role play those things. And individual therapy allows for that. And then that individual focus helps that person feel like or understand that they have a safe place, they have somebody that they can trust, and somebody that will personalize and be present with them when they need them. So group counseling is supposed to be another safe place, but again, with the dynamic of fostering empathy and peer support, as I have already discussed, it also helps to promote diverse perspectives and discussions. Obviously, when I talk to you, you're getting my perspective on things. I might be able to bring in things I've heard from other people or seen in other situations, but I don't have an understanding of them as somebody who lived through those things. So that group process allows for the exposure of these individuals to the varied experiences, and that helps create a better self-awareness and growth. When somebody in here, I had somebody this morning, for example, they have some insecurities about things, they don't feel comfortable talking about it, but when they hear those things talked about in a group session by other people in those situations, then that helps them see, okay, I'm not the only one, it's not the only situation. And then this isn't the horrible thing that I think it is. And then obviously group counseling enhances social skills and communication because there's a participation there. And there should be somebody that is managing or monitoring that situation so that it doesn't get out of hand. Sometimes though, it does get out of hand. And then family counseling obviously allows for bringing everybody in that family system who wants to be a part of the therapeutic process to come in. It helps for mediation of disputes, understanding, communication. Typically, just like in every behavioral health or mental health professional, we don't say, well, you're right and he's wrong. We teach things like active listening or fighting fair. Fighting fair, for example, is we don't bring up the past. We only talk about the issues and we don't call each other names. So very foundational, basic type things. But when your emotions are high, when you're dealing with serious situations, or when your frustration level's high, or when your resilience level's low, those things kind of go out the window. So family counseling helps to improve that, helps them understand better how to communicate. It builds empathy and understanding, and then helps to promote more positive relationship dynamics through all of that trust, empathy, and cooperation, and learning that you're a part of a system. And being a part of that system doesn't mean you're always right, you're always wrong, or that it even matters who's right or who's wrong. The holistic approach means that we're considering the different emotional factors in therapy. We're addressing emotions to help clients process and manage feelings effectively for better outcomes. I taught anger management to adolescents for years. I started to develop psychosomatic issues on Wednesday mornings because it was always Wednesday evenings. For 10 years, I did 3 hours, 3 different groups with adolescents, 10 to 20 adolescents in a giant room for an hour at a time for 10 years. They ranged from 12 to 19, and it depended on, the makeup of the group. And that was fine, but again, very difficult, took a lot out of me. After doing that about 6 or 8 years, I was approached by the adult probation office to do anger management for adults. And that was much easier. Dealing with adults is a lot easier than dealing with adolescents, at least in that section. Oftentimes there were adolescents who would get worse from the group process. But I remember the very first group I did, a guy said to me, "This is BS. Why am I in here? Everybody gets angry. You're trying to tell us we shouldn't get angry." That's exactly what I'm not trying to tell you. What I'm trying to tell you is that everybody gets angry, but not everybody burns their house down when they get angry. Not everybody beats their spouse up when they get angry. Not everybody wrecks their car when they get angry. Whatever that situation is that led to them having to come to that anger management group, most people don't reach that level. Now, every once in a while we might. I think when I was in college, I broke a mouse, the computer mouse, because it was sticking, and I got frustrated. And immediately afterwards, when I had to go buy a new one and they cost $30 at the time, I thought, well, that wasn't very smart. But we all have those reactions from time to time, maybe obviously not to that level, but the goal is to understand and appreciate that we all have these feelings, and that the feelings are okay and the feelings have validity, but it doesn't mean we have to act out this way. How can I handle and process these feelings more effectively so I get better outcomes that I don't regret later? And then we help them understand how psychology helps to identify, or the mental health process helps identify the root causes. What is it that's driving this? Oftentimes, we used to, displacement was something we talk about from Freudian perspective from years and years ago. You have a bad day at work, so you come home and you kick the dog when the dog looks at you funny. You're not angry at the dog. You're angry because you had a bad day at work, but you didn't cope with it very well, so you took it out on the first thing that was there, me and the computer mouse years ago. So we want to help individuals identify what is it that's driving my emotions, which are making me act this way, or contributing to me acting this way, or making me feel this way. And then we try to put that in a social context. That goes to it's okay to feel this way. One of the examples I used with my children when they were growing up is my daughter said, "So-and-so was talking in class, and I can't believe it. You should never talk in class." That's not true. There are certain classes you're expected to talk in. And somebody just the other day said they were eating in this situation. You should never eat in that situation. Well, that's not true. Sometimes you have working lunches where you do eat in those situations. I went to a breakfast meeting a couple months ago, and people were eating while we were having this meeting. So context is super important. And the various social factors impact what is appropriate and inappropriate. So it's important for us to be able to help identify what those are. So again, looking at the different modalities, we've talked about cognitive behavioral therapy. DBT is dialectical behavioral therapy. ACT is another one that's used a lot of times to enhance the treatment flexibility. But we have active listening and CPT, cognitive processing therapy, and we have REBT. We have Rogerian or person-centered approaches. We have I work in forensic settings, as you noted at the very beginning of this. So I use something called reality therapy. It's a type of therapeutic intervention that was developed by somebody working in prisons. So it's a very different approach than, well, tell me how you feel today. Working with children oftentimes is much different than working with adolescents, which is oftentimes much different than working with adults, which is oftentimes much different than working with the geriatric population. But we all know that working in this profession. So having the different approaches gives us lots of different tools in our bag that we can use. And having an individual who understands these different approaches is most effective. And then obviously taking the tools that we have that fit within our personality. I can't use a therapeutic modality, for example, that doesn't fit with my personality. It feels forced and it feels wrong. It's inauthentic. And there are certain treatment modalities that I'm not effective at, and I don't use them because they don't come across as authentic and they're not effective. But if I have somebody who needs that therapeutic intervention, one that comes to mind is EMDR, not because I don't believe in it, it just doesn't fit with the types of things that I do or my kind of more active personality. So if somebody has trauma and that's a treatment modality that might be effective with them, then I have no problems referring them out to somebody for that. Understanding and appreciating my limitations, and understanding and appreciating that I have an ethical and moral obligation to whoever the patient is to get them the best treatment that they need without my ego having to get in the way. Because we have to tailor therapy to the individual. It has to be personalized. We have to make sure that the client gets it and they're engaged. We have to make sure that they feel good about it. I love working with children. I didn't think I would when I started out, but I love it. Every time a child or adolescent comes to my office, the very first day, they don't want to be here. They're scared. They're nervous. Some strange, weird, old, bald guy is going to talk to me today. When I started out years ago, I had beautiful hair, but this job, probably having twins is most effective. Not my genetics. I'm sure it has nothing to do with my genetics. Sorry. But when they leave here, my goal is to have such good rapport with them that they want to come back. And I tell parents or grandparents or whoever the guardian is that when they leave here and you ask them what we did, they're probably going to tell you we played, or we talked about pizza or foods that we like, or sports or movies, whatever it is, because I'm trying to build rapport. I want them to feel comfortable and safe, and then this can become a dynamic process for them. So everything has to be customized to enhance those things. We have to make sure that we're sensitive to and address cultural, socioeconomic, and personal factors so that we deal with the individual. We're not dealing with the same person every day, even if it's the same person every day. They come in a different mood state, they come in with different experiences, and they come in with different motivations. So we have to be flexible in those things. Oops. We also deal with a spectrum of mental health disorders. There's very few mental health disorders that LPCs don't work with. Now, I'll tell you, if you come into me and you say I'm a cocaine addict or I have an addiction to cocaine, I will say I have awareness of that and I understand it, but it's not something that I'm very effective with, so I'll refer you to somebody else. But there are LPCs that do work with cocaine addiction. If you come in and you tell me you have issues with your children, or you have issues with autism, or you have issues with anxiety or PTSD, those are things that I can help you with. If you need an assessment for different things, we can help you with that. ADHD is the #1 chronic issue that we deal with related to children and adolescents, and now we're starting to see it more so in adults. So we have the ability, the education, the training, and the experience to deal with those things. Obviously, we have an ethical, legal, and moral obligation to not treat somebody who we're not good at, something we're not good at. As I said, a cocaine addiction. If I work with people who have eating disorders and then somebody comes in with an addiction to a significant substance, then I'm going to have to refer them out. But I know different LPCs who do that. So there are LPCs who are trained in any psychological, behavioral, mental, emotional problem or disorder you can think of. Neurological gets a little bit more specialized. The work that I do is forensic, which is not healthcare related, but court related. So that's a little bit more specialized. Sex issues tend to be fairly specialized, but everything can be specialized. There's a certain therapist I know who almost exclusively works with eating disorders. There's therapists I know who almost exclusively work with substance use disorders. So it doesn't mean they don't have the training or the education or the experience to deal with other things. It simply means that that's the thing that they feel most confident in working with. But there's an LPC for just about anything, just as there are other behavioral and mental health professionals and medical professionals who have different expertise and specialties. So obviously having those effective treatments for various difficulties, that enhances treatment, because a lot of times there's comorbidity, right? If I have somebody who has anxiety and depression and I have an understanding of both of those things, there's a lot of overlap in those two areas, then it's something that I can do. Obviously also having an understanding of the welfare type things, the holistic, not the holistic, the wellness approaches, good diet, sleeping good, exercise, all of those things are part of the holistic process. So we also have the ability to address complex issues. Most of the individuals who come to us aren't coming to us because they're getting divorced and they're processing through adjustment difficulties. They're getting fired, they're getting kicked out of school, they're getting arrested. they're losing their relationships, or so bipolar disorder, schizophrenia, schizoaffective, delusional disorders. There's specialized training in all of those areas. And when we have those things, we can find individuals that can work in those areas. So obviously trauma and PTSD is very specialized. I try to, everyone I work with within my practices, we make that kind of an overlay for everything. If understanding the whole person is the foundation, then trauma is the overlay. So we build up that person and we say, we need to do a deep dive into trauma to rule that out or to address it before we can really get into other things. Supporting clients with personality disorders. It's one of the, again, a major thing we deal with: borderline personality, narcissistic personality, antisocial personality, histrionic personality, those cluster A and cluster B disorders. We have training in those things, and there are people who work with them. I specifically don't enjoy working with that level, but I know LPCs and other mental health professionals who do enjoy and excel at working with those individuals. I don't enjoy working with adolescents, but I know people who excel at that. And then again, specializations in addiction recovery we talked about. And then different age groups. I think we've addressed this pretty well. From infancy, toddlerhood, there are therapists that work with, obviously we're not doing talk therapy with a 2-year-old necessarily. There are some fairly verbal 2-year-olds, but we're doing play therapy, or we're doing family therapy, or we're doing behavior therapy, all the way up to geriatrics. And there are different specialized techniques for all of those things. And we have to address those and have understanding and appreciation. When I started, the expectation that adolescence, it ended at about 18, but now the young adults, we see similar problems from 18 to 24 to 26 as we see with 16-year-olds, as our society is shifting in those ways. So personalizing those things. My last patient before coming to this presentation was a geriatric patient. He's 100 years old. So obviously the things that I talked about with him and how I built rapport with him was a lot different than what I would do with a 7-year-old. So we have the specialized techniques and understanding of those things. So one of the things we want to increase in professional collaboration, we want to make sure that there's good awareness that mental health and behavioral health issues need to have the same level of support and identification and understanding as anything else within our field and our profession, and we all need to work together to make that happen. So we've talked about all of these things and how we work with physicians and psychiatrists and social workers, how we and case managers, how we work in a coordinated way for patient care, how we advocate for mental health awareness, how we work in different communities and do education. I do presentations all over the country for things like this. I typically prefer more interaction than this, so that it's much more didactic, but it is what it is. So I believe that mental health care plays a key role in whole health, and that professional counselors provide essential support to holistic well-being. I want to reiterate that the LPCs have a minimum of a master's degree and a minimum of 2, most states are 3 years post-master's training in addressing supervision, in addressing a wide variety of mental health issues. I would say the entire spectrum. Not all of us deal in all of them, but you know what I mean. And then we have a lot of expertise and experience in it with different healthcare providers. So we really want to, one of the American Association that I am the executive director on, we really want to work really hard to push cultural competence in treatment, to make sure that we're aware of individual differences and group differences within the populations we work for, and then advocate for marginalized groups. Inclusion is super important, and children, minorities, other marginalized groups, those are the ones that I want to help and make sure that they have a voice and that they may have a safe place that they can go to, not so they can hurt other people or try to hurt other people or make other people's lives miserable, but so that they can process whatever it is that they're going through. So there are lots of community outreach programs that we work in. Telehealth services have made things vastly more accessible, especially in rural areas, but I find it's the same in urban areas where somebody it might be 5 or 6 miles away, but it's a 30-minute drive because of traffic or difficulties. You might have somebody with agoraphobia or anxiety disorders, and they're much more successful at engaging in that way as opposed to driving across town or having to deal with parking. When I first started my own individual therapy dealing with PTSD, the parking lot where my therapist was an issue for me, and I struggled with it. But obviously, over time, I got better at it. It doesn't bother me anymore. But we all have those crosses to bear, I guess. And we've talked about inclusion. Whoops. Being inclusive, diversity-centered treatment programs, and then empowerment for inclusive practices. We've talked about this, work with a lot of multidisciplinary teams. We work with schools, we work with physicians, we work with other healthcare providers, we work with PAs and nurses, we work with specialty groups, we work with hospitals. We try to be as integrative as possible when appropriate and when necessary. And then empowering patients to improve outcomes and adherence. Obviously, psychiatrists are a big part of our collaboration. There's very few individuals I work with these days who don't have some type of psychotropic medication that they're on. Not everybody, but I would say the majority. So we have a good understanding and training in understanding psychotropic medications and what they do. Obviously, that's an ongoing process because it changes sometimes weekly, it feels like. We've talked about this, and then this we've talked about. Advocacy is a big issue we've talked about. Community education, my offices, we go out to the community and do events to foster knowledge and understanding of mental health and the issues. One of my offices is in the military community. When I first started, every patient we had was the children in the military community, and now it's a lot more of the adults, not just the spouses, but active duty and retired individuals as well, because we're becoming more accepting of the need and understanding the stigma is going away, and that's because of the advocacy and community outreach that we're all doing. So I truly believe that LPCs and other behavioral health and mental health providers are vital in the role of healthcare. I don't know what this picture has to do with anything, but it's a little hypnotic. So, and we've talked about this, just kind of reiterating those things and summing everything up. It's impossible, just to reiterate one last time, how for anybody to truly process and improve if you only address one aspect of their difficulties or their life, social, cultural, mental, physical, emotional, behavioral, all of those things have to be included. And it's a role that we play significantly that for a long time was overlooked, but I think is not as much overlooked anymore. So we've talked about this. One of the things we try to do in the advocacy is help-seeking behavior. What are things you can do to help yourself? We collaborate with high schools, middle schools, elementary schools, universities. We collaborate with the DoD. We collaborate with the Department of the Army, Department of the Navy, Air Force, all the branches of the military, the VA, to try to make sure that people have access to the support services they need. So I hit on this a little bit, but we do comprehensive psychometric testing. We can provide those evaluations. We call them mental health evaluations. That is necessary to get an accurate diagnosis. You want to make sure that you have precise identification of what exactly is going on. So we use assessment tools, tests, we use clinical interviews, we use record reviews, we use the biopsychosocials, the social histories, collateral information from talking to other healthcare providers, the schools, things like that, so that we can get more effective and targeted treatment plans. We don't want to just throw stuff at the wall and see what sticks. So, and again, that leads to personalized treatment and allows for progress tracking, right? We do pre-tests and post-tests. We can measure your level of depression, for example, then do an intervention for 4 to 6 weeks or 2 weeks or 6 months, whatever it is, and then go back and re-review to see where you're at with that. So, and then crisis intervention we talked about, and then life-saving interventions goes along with crisis interventions. So I hope at the end of this, you all see and appreciate we are an important cog in the wheel of the healthcare system. We have many brothers and sisters and colleagues in other behavioral and mental health areas, and our level of education, training, and experience is commensurate with them in a lot of areas. Some things we have more training in some things, not as much, but as individuals, we have the opportunity to go specialize in a lot of those areas. We can be a great initial resource for people coming in. We can help open doors to other resources. And then we can be kind of foster improvement for individuals who are discharging from medical treatment or in the process of medical treatment for outpatient treatment to enhance their outcomes through our partnerships and collaboration with other professionals. So I think as we move forward, the integration is going to continue. I hope that we continue to see improved outcomes because we're using this more holistic care. I hope it's not lip service, the information and direction that we're getting from the managed care providers, the insurance companies, that they want more of this integrated care. I know it's frustrating dealing with those things, and we don't have time to get on that soapbox, but it seems like that is the direction where whole health and holistic care is the emphasis, and that allows for greater collaboration, and that leads to better outcomes. That leads to less cost for us as a society, less cost for us as individuals in our own lives, and less cost for our families as we move forward. So, thank you all for listening. I hope it was informative. If you have any questions or concerns, again, this is my contact information, tom@aafp.pro. I will get back to you within a day or two if you email me. Thank you all for listening, and good luck with the rest of the conference.